Welcome. My name is Kathleen Yoder, and I am presenting Education on Labor and Support Techniques, an Evidence-Based Practice Proposal. Both the nursing and medical professional organizations for obstetrics recommend the use of continuous one-to-one labor support for all women. Labor and delivery nurses play a key component in providing continuous labor support, as they were able to use both their aesthetic and empirical knowledge for optimal care of the patient. Using Martha Rogers' theory of unitary being, labor and delivery nurses foster strong relationships with their patients and are able to use creative techniques to control the environment around the laboring patient. On my high acuity labor and delivery unit, I have identified that there is a lack of knowledge of labor support techniques and continuous labor support provided to our patients. Some of the reasons include higher turnover, an increase in advanced beginner nurses on our unit, no formal training in labor and support techniques during orientation, and the lack of confidence in labor support from the nurses. The problem that I have identified is the lack of knowledge related to labor support techniques, secondary to no formal training currently during orientation. So my question is, will labor and delivery nurses of less than 3 years who attend an educational session on labor and support techniques score higher on a survey after the training than before? So when we look at the literature, we can see why it is so important to have education on continuous labor support and labor support techniques. Currently, 31.7% of all deliveries in the United States are via cesarean section. The World Health Organization recommends that cesarean section rates be between 10 to 15%, with vaginal deliveries being the preferred mode of delivery. We also know that women with doula-supported births have a higher incidence of initiation of breastfeeding. Postpartum post-traumatic stress disorder affects between 3 and 4% of all women after birth and can have a significant effect on subsequent deliveries. Currently, patient satisfaction scores also play a key role in hospital-wide reimbursement. Now let's look to the literature to see the benefits to continuous labor support. In an IRB-approved single-blind study of 72 participants, where the purpose of the study was to assess the effects of intrapartum support care on fear during delivery, an intervention group received continuous labor support, and the other group received standard care provided by the hospital. The support was provided by nurses in the labor and delivery unit. There was no significant education to the nurses for their labor interventions. What was found was that patients in the intervention group scored significantly higher in the perceived care during their delivery, as well as a significant decrease in pain scores. The researchers concluded that there was clinical benefits to women who received continuous labor support, and in the future they should do a double-blind randomized control study for this research. Next, in a phenological qualitative study whose purpose was to explore the women's expectations from delivery nurses during a vaginal delivery, a sampling of 12 women, all being over the age of 18, with the willingness to participate and no psychiatric diagnoses, were interviewed and videotaped and asked semi-structured questions regarding their primary expectations from their delivery by researchers who are trained in qualitative studies. The results show that patients felt they had a fulfillment of their personal needs done by nurses, and that they had a more positive feeling and more positive outlook when their nurses were at their bedside during their delivery than when they were left alone in their delivery room. It is also to be noted that this study did have some limitations, as is done at one small regional area in Turkey, where family members, including spouses, were not allowed in for delivery. The researchers concluded that feelings of loneliness were absolved by the nurses who were spending time with patients during their delivery. Additionally, there could be some added benefits to family members being allowed to participate in the delivery process. A review of the literature has also shown that supporting women in minimal interventions leads to a decreased risk in postpartum post-traumatic stress disorder. Some monitoring of cortisol levels in laboring mothers post-delivery showed that laboring mothers who received continuous labor support had decreased cortisol levels than their counterparts that did not receive continuous labor support. We can conclude from this that those mothers had less stress than those without. We also know that there is a higher incidence of vaginal deliveries that occur when patients can have continuous labor support. Now let's see what the literature says about the clinical implications to continuous labor support. In a quasi-experimental pre- and post-test design descriptive quantitative study where the purpose was to describe the development and evaluation of labor and support workshop aimed at improving undergraduate senior level nursing students' self-reported knowledge and attitudes towards labor support. A sampling of 69 undergraduate nursing students in their first semester of their senior year with voluntary participation and remaining anonymous were provided a 2.5-hour labor support workshop. The participants were broken up into groups of 6 to 8 to allow for smaller hands-on teaching time. The students were asked to complete a pre- and post-intervention survey with a Likert scale and open-ended questions to measure their knowledge and self-efficacy. The results of this test showed that pre-test, most of the nurses' students believed that labor support techniques included communication, breathing, and encouragement. However, the post-intervention assessment showed a large increase in knowledge regarding the various labor support techniques. The students were then able to identify other techniques such as aromatherapy, lower back counter pressure, hot and cold packs, lighting, and the use of birthing balls. Some of the limitations to this study included the fact that it is unaware of whether or not any outside interventions besides the educational training could have increased the student nurses' self-efficacy scores. The researchers concluded that there was a strong increase in knowledge of labor support techniques after students had received formal training. Next, we see that in a QI project in participation of the Reducing Primary Cesarean Collaboration, nurses who received education in labor and support techniques showed an increase in their self-efficacy scores. Lastly, in an IRB-approved study of 23 inpatient labor and birth nurses who were collected using convenience sampling all over the age of 19 whose primary roles were direct inpatient care and did not include patient care technicians, LPNs, or surgical technicians, received a structured pre- and post-intervention Likert scale questionnaire. These nurses were provided with an algorithm for comfort measures for patients. Between the pre- and post-interventions, the nurses showed an increase in the amount of times that the nurses perceived that they were providing continuous labor support. Now that we have the knowledge of continuous labor support and the research which supports its need, I'm going to explain my process and plan for a QI project at Hartford Hospital on their labor and delivery unit. I started this process by collaborating with a fellow University of Hartford MSN student on my unit. We have contacted our nurse manager and educator and presented them with the problem that we have identified in order to get approval for the QI project on our unit. They have played an integral role in supporting us as we have begun this journey on this project. They have gotten us in contact with the Hartford Hospital nursing scientist who is in the process of guiding us through the channels of approval for this QI project on our unit, and next month we hope to be meeting with the Nursing Research Council. So to begin, our plan is to have all nurses with less than 3 years labor and delivery experience take a pre-survey of their knowledge of continuous labor support and labor support techniques. We will then provide them with an online educational module and a formal hands-on training class. We will then have them do a post-survey which will be linked to their pre-survey. Each of this will all happen over the time of 1 month. Before implementation of our project, we have already identified a few obstacles. Our main obstacle includes not having any financial backing for this project. With that said, we have found that the American College of Nurse Midwives has a free online educational module on continuous labor support, and we are currently awaiting approval for use on our unit. Once we have permission from the hospital and our unit to disseminate this information, it will be uploaded to our hospital's online learning platform for our participants. In addition to the financial obstacle already identified, the COVID-19 pandemic has provided more obstacles. We have been told that we are not allowed to bring in any resources from outside our hospital who can assist with training and labor support techniques, and this includes doulas, even if they're volunteers. The classes also will have to be held in smaller sizes to allow for social distancing. We will need to wear masks for the entirety of the class. Currently, our plan is to have a 30-minute hands-on class, which will be provided by current staff members who have taken training in labor support techniques. If we are unable to provide for these classes, we may have to take the participants one-on-one during working hours in order to provide the labor support techniques and allow them to practice. Outcomes will be measured on a 7-point Likert survey. This survey will be provided pre and post education. The surveys will be linked so that there will be noticed whether or not there is individual increase in knowledge between interventions. This will then use basic statistical analysis to evaluate for any change. Upon completion of our analysis for the outcomes, we plan on disseminating this information out to all the staff members. We have permission from our manager, nurse manager, and educator to place this information on our lean board, which is gone over Q shift with each of the staff members. Additionally, our assistant nurse manager sends out a weekly update to all staff members on happenings on the unit, and our perinatal safety nurse will also place it in the perinatal safety news, which comes out quarterly. Our educator has told us that if we are able to show significant increase in knowledge on continuous labor support and labor and support techniques based off our surveys, she will then incorporate our project into orientation for all new labor and delivery nurses. At this time, I would like to thank you all for listening to my presentation, and I would like to thank Dr. Sherry Carl for her guidance and support for this project. Thank you.